that resonates and also that just teaches me things, right? So I honestly have, even being in upstate New York, where I'm surrounded by farms and farmers, honestly, I really haven't thought about the way that, for example, farmers as a community can factor into the discourse that we have about Medicaid. And the same thing with thinking about folks who have substance abuse disorders. And there's just a ton for me to learn. So I don't have any slides for this portion for two reasons. One is because I want to keep it relatively short. And two is because I'm assuming, like, I just had so many slides before that I don't want to overwhelm everyone with slides. So I'm going to just talk through with you all, but I want to, some of my ideas around solutions, right? And they're kind of across different levels. And I want to flag at the outset that I actually don't think I'm best positioned to really be coming up with solutions, right? And this taps into what, I don't know your name, but what the person who shared that amazing set of thoughts in the audience, the nurse practitioner, said about kind of the idea that the folks who are making the policies are thinking about it from their vantage point and not understanding all that is entailed in this. And one of the things that I have been, excited about, but at times also unsettled about, is how since, publishing the book, how many people have reached out to me and said, we want you to come and talk to these policymakers, we want you to come and talk. And it's like, I'm at the state capitol or I'm in DC, and oftentimes what I am telling, folks are looking to me for insights, like what are the policies we should be implementing? And what I end up saying is, the first thing you should be doing is talking to people other than academics like me, right? Yeah. So part of the people say, well, you've talked to Medicaid beneficiaries, so you know things. You should tell us those things. And one of the things I say is like, okay, but you could also talk to Medicaid beneficiaries, right? And talk to the folks who are most connected to them. So I think as a kind of like baseline beginning for thinking through like policy solutions, separate from concrete solutions, which, I'm happy to talk through some and will, there's a kind of like institutional mechanism way of thinking about solutions. And I think, Lynn Quincy introduced us to an idea like this when she was talking about the healthcare consumer, agencies are having an institutional mechanism that can amplify and embed the voices of Medicaid beneficiaries and the folks who work most closely with them, embed those voices into the political process, right? So instead of, Kentucky Voices for Health, other organizations, sometimes individual people, kind of fighting and pushing to be able to be a part of that process, right? And to be able to amplify the experiences and voices of beneficiaries. For that, in as many ways as possible, to already be baked in, right? Such that it's hard, impossible, to not take that into account, and also impossible to kind of claim ignorance, right? Well, we did this because it seemed reasonable to us. We had no idea that hundreds of thousands of people were going to lose their benefits, right? In many ways, policymakers now have cover to claim that kind of, well, we didn't know it. Everybody likes hard work. This seemed reasonable. And so that's thinking about a variety of different mechanisms for building into a kind of institutional infrastructure. How can we make sure that there is not a policy that can get passed about Medicaid that has not at various stages of the process included the voices of Medicaid beneficiaries themselves? And in many places, there are just no official mechanisms that allow for that sort of thing. So thinking creatively about what those look like is important. A second kind of institutional structural level policy point is around pushing so that there is robust, and no one here really needs me to tell them this, but robust evaluation, right? Because there's so much happening right now, there's so much policy change, and depending on the state or the locality, there may be policies being implemented. There are policymakers claiming that those policies are going to achieve certain ends, that they're going to be good for people, that they're going to save money, but conveniently not building in any mechanisms for evaluating and measuring the effect of those policies, right? So then it's really hard to hold folks accountable. It's like these work requirements are going to be good. They're going to lower cost. People are gonna have skin in the game, right? This is what we, I don't know, I really hate that, right? Everybody already has their whole body in the game because your health and wellness depends on this. But, you know, we can make these claims about what policies are gonna do, and if we also don't fund and create mechanisms for evaluation, we never have to be held, or not for a very long time, have to be held, have our feet held to the fire about whether it's true about what actually happens when the policies are implemented. And so I think having evaluative mechanism, or funds for evaluation, mechanisms for evaluation built into more in any policy that's passed, so that we're making policy decisions based on evidence and not based on perceptions, right, that are often misguided. And, you know, perceptions are often just stereotypes, right? They're just ideas that we have about people who aren't us, those other people who need Medicaid in order to have health coverage, right? So those are two kind of meta level things that are just about the kinds of input that we need in order for policy decisions to be sensible. We need input from the core stakeholders, which are beneficiaries, and we need evidence about the effects of the policies we've already passed. And it's always astonishing to me when I go to different events around Medicaid and people are saying stakeholders, that's a term I realized very quickly was very popular. And one of the first things I did at one of these meetings in DC where people kept saying stakeholders, and I raised my hand and said, could somebody tell me what they mean when they say that? And a few people kind of rattled off, you know, who they're thinking of when they say that. Did not mention actual Medicaid beneficiaries. And I said, okay, so are the people who rely on these resources, are they stakeholders? Oh yeah, of course. Okay, why are we talking about that, right? So to kind of reclaim this notion of like stakeholders having a say, right? We're certainly, I mean, I think a lot of policy elites when they're thinking about stakeholders are certainly thinking about kind of business interests, and are certainly thinking about sometimes different civic organizations, not always to differing extents. We're really reclaiming the kind of the imperative for the core stakeholders to be at the center of the process. Now, part of what that means also is providing the infrastructure to make that possible. Because Medicaid beneficiaries, like I talked about before, I mean, it's amazing that we have folks here today who are beneficiaries who can speak to their experiences. That's absolutely crucial. That's a sacrifice, right? That's work that you could be getting done that you're not getting done. That's travel, that's emotional, intellectual, all other kinds of energy. And so thinking about how to build into policy, not just the kind of input of a broad range of stakeholders, but ways of kind of supporting folks as they're being kind of asked to provide that kind of input. So when I interviewed a really powerful group of women, they were all women in Iowa, who were Medicaid beneficiaries and also activists, who, as the state was transitioning to a managed care system that they all really opposed but just didn't really have the power to be able to hold off, what they decided they could do was try to influence the implementation of managed care to kind of, as it was designed in Iowa, to blunt some of the negative effects that they were worried were coming down the pike. And they did an amazing job of mobilizing around that. And one of the reasons that was possible was because they were provided with resources to do so. So one of the primary organizers of the kind of small movement that went on in Iowa was a woman who had, through several grants that she was able to get, been able to pay for the transportation of Medicaid beneficiaries to get to the state capitol on a regular basis. So that every time there was a hearing and every time there was anything that implicated or involved Medicaid in any way, they had 75 or 80 people there ready to speak, right? And that wouldn't have been possible if it weren't for resources to kind of support the voices of and inclusion of Medicaid beneficiaries. Not like, if you force us and somebody happens to show up, I guess we'll listen to you. But we're actually investing in making sure that these voices end up coming to the table. And it's not a huge investment, actually, but it's in terms of amounts. But it's huge in terms of what it signifies and what it could potentially create in terms of outcomes, policy outcomes. So I'll just say a few more things very quickly to sort of get us thinking, and then I'm sure that there are more and better and different and some deeper ideas in the room, I would imagine, than what I have to offer. So a few things. One is Medicaid, thinking about how to, there are kind of thinking about which voices to include and how, and then there's thinking a few things about, so for me, I think a lot about how to kind of but make sure that we're designing policy that recognizes the political problems or the political barriers that prevent us from having policy outcomes that reflect what people want, right? So I was really struck by Lynn's presentation earlier when she said, but look how much agreement there is, right? Look how much agreement there is. Most people want to have a healthcare system that doesn't where there aren't costs accruing for them, right? Or that doesn't kind of saddle them with significant burdens. And most people understand the system as it is isn't working. There's disagreement certainly about how to get there, but there's also a significant amount of agreement about some of the ways to get there. The question is, in this context where there's some level of diffuse support for policies, but that level of support at the kind of population level, at kind of an ordinary people level, doesn't translate up, right, to what's happening with policy. And so I think a lot about like policy mechanisms that help us to get there. So a couple of things is, one, I think that we have to think about policy that's improving outcomes for Medicaid beneficiaries and improving access and equity in the healthcare system in a way that doesn't carve off Medicaid beneficiaries entirely, right? But thinks about the system holistically. And the reason why I think that's important is because some of the reasons why what I think, based on some research that I'm starting to do now and kind of intuitions that come from some of the research that political scientists have done more broadly, is that to the extent that I think we've all agreed that like a kind of universal approach is the long-term goal, right? The question is, how do we pass policy that both helps people immediately before that long-term goal is even possible, and that also brings us closer to that universal, or to that long-term goal. And one of the ways is to think as we go along, as we proceed through the policy process, about how to bring together the interests of Medicaid beneficiaries and other folks who just want costs to go down and who just want the system to be more manageable and more responsive to their needs, such that Medicaid beneficiaries aren't carved off and stigmatized, right? So we can take things away from them, or we can make life harder for them, and so that people can recognize their interest and work together. So I think some of what that means is that we want to think about, and Lynn presented us with some great options, policies that are making life better for people who have private insurance, people who have Medicaid insurance, Medicare insurance across the board. And so some of these meta-level policies around costs, around transparency are great, and for the reasons that Lynn pointed out, but also for some other reasons, which is one of the things that I've been picking up in some of the survey work I've been doing is a growing resentment towards Medicaid beneficiaries among non-beneficiaries, right? And part of the reason why is because non-beneficiaries understand the healthcare system to be very difficult for them to navigate, very burdensome for them, very expensive for them. And it gets folks to the point where they're like, well, I'm working, and I'm responsible, and I have private insurance, and this is still so hard and costly and burdensome. And they imagine that over there are these other people relying on Medicaid and just kind of cruising through, getting everything for free. And it generates this kind of resentment, right? That's not actually what's happening over there with Medicaid beneficiaries, but to the extent that people getting private insurance think so, there's now a perception that their interests are divided from the interests of Medicaid beneficiaries. It's that much harder to mobilize and to make things happen politically. So I think these policies that are simultaneously affecting both beneficiaries and non-beneficiaries, and there's a whole slew of them, right? Too many for me to kind of go through in detail here. But I'm trying to paint a kind of meta picture of the kinds of policies we should care about and we should prioritize. Policies that amplify the voices of Medicaid beneficiaries, policies that unite the interests of beneficiaries and non-beneficiaries so that we can get more of folks working together as opposed to, I want to protect my corner over here, I want to protect my corner over here. Our interests are divided, right? So that's one thing. And then I guess the last thing I would say is that it's really important to think about policies that are going to have, to think about in terms of policies and how to think about them in a meta way, policy solutions. We want to think about policy solutions that have both short-term effects that provide people with immediate relief, right? So many people, and again, Lynn's data emphasizes this for us, and this is what beneficiaries tell me, have immediate challenges and problems that they deal with, right? So this is why, for example, healthcare navigators are so crucial, right? And anyone who makes the system easier to navigate on a day-to-day basis is so crucial. And so investing in those sorts of actors matters tremendously. And again, I need not convince any of us of this, but because it provides people with short-term relief, right? But as it provides people with short-term relief, it frees them up capacity-wise to think about, to even think about engaging, right? And it gives them a civic connection that can motivate that engagement. Wait a minute, I wasn't in this alone. I had a navigator. I had somebody here who helped me. Oh, and this person is associated with X or Y organization. It's both an avenue for people to be able to engage more deeply, and it provides them with immediate relief. And so as we provide short-term solutions, we're building civic infrastructure long-term. And what I think in terms of the kinds of solutions we might want to turn away from are solutions that provide short-term relief but erode civic infrastructure. So I was at a meeting a few weeks ago with some folks in DC who I said, who said, I know what we need to do. Part of the problem with Medicaid is that it's Medicaid. And so people aren't going to get substandard services. We need to find a way to fold all of these services into the private sector, where the kind of market imperative is going to get people better consumer, right? The private consumers are probably getting better customer service, and so let's try to find a way of merging all of these things, right? And this is a policy approach that, depending on the political environment, can have quite a bit of appeal. But one flag I raise around that, I think that we need evidence on those kinds of policy approaches to make sense of them. But one kind of like broad flag I raise around that is that, to the extent, and political scientists have been doing research on this, and we can show this better and better, to the extent that we develop healthcare systems where people who are being helped by the government don't know they're being helped by the government, because they think it's a benefit that the private sector is giving them. The long-term effects of that politically are worrisome, right? My colleague Suzanne Mettler has a great book called The Submerged State, and she has a new book more recently called The Government-Citizen Disconnect. And what she shows is that more and more government policy is being submerged. It's occurring through the private system, or either through the market or through some mechanism that people don't realize is the government, right? And so people have these overwhelmingly negative views of the government. They don't understand what the government is doing for them, and so we want government to be smaller. We want government out of our lives. Less government, right? And part of that is because they don't realize what the government is doing, because those functions are being folded into the market in a way that submerges the role of the government. And so while it may feel like one solution to some of the challenges here is to figure out how to marketize more and more of what's happening with Medicaid or Medicare or what have you, right? Or even in the private sector, to minimize the visibility of the role of the government in structuring and regulating the private sector, there are political, forces that push in that direction. And while in many ways it can be appealing, the part of it that's worrisome are the democratic consequences. Because if people don't realize that the government is involved, if they don't realize this is political, the signals about how engaging politically matters, and the motivation to do so is going to be blunted. So again, these aren't specific, here are the policy the policies we should pass, right? I assume that you all have many more of those than I do. But here are the things we should be thinking about as we imagine which policies to pass and to advocate for, right? We should be thinking about the engagement and input of beneficiaries and centering that. We should be thinking about the kind of long-term political effects, the feedback of the policies, as well as the short-term benefits of the policies, and balancing that. We want to provide people with short-term relief, but not in the way that undermines our long-term political goals, right? Those are just the overarching kind of factors to consider as we think about how to proceed as far as kind of policy approaches, right? Okay, I'll stop there. I'm probably over time. I didn't check myself, but I'll stop.
You're not at all. I think we're doing great on time. You did give us a lot to think about, so I'd love to hear people's thoughts and questions. I have to say, make my own comment. I think so often about what you were saying about government benefits or government, sort of government involvement, I guess, in healthcare, especially in the private sector, in employer coverage, not being seen, so it's not transparent. People don't appreciate it and don't understand it, don't realize that they're benefiting as well. And I actually have thought with the Affordable Care Act specifically and with the resentment toward Medicaid beneficiaries that is a big part of the problem. That people think everyone else is getting something but me, and in fact I'm paying for it. And don't realize that there is a lot of subsidy happening with employer coverage, and that Medicaid is actually really cost effective. And in fact, we are probably paying generally less per person, typically, in the Medicaid program than what we are necessarily in subsidizing other types of care. And so I don't know how we have those conversations, but it occurs to me all the time that is what has created that division, where people think that they have separate interests, but really their interests are exactly the same. So anyway, thank you for making that point and making it so eloquently. So, questions?
Thank you again for talking. I did want to make a note, just because you talked about the resentment of non-beneficiaries and Medicaid, and that some people who are paying into these private insurances or taking advantage of their employment insurances are not taking into account those who are not meeting the requirements to have these insurances by their job, or they're smaller employers and don't actually have insurance available to them other than the governmental insurance. And so it's very important that we bring that a part of the conversation as well, because these people who are still working and are still able-bodied, but because they don't have the requirements availability-wise, they are not able to tap into this private pay system or healthcare within their employer's network. Now, I did want to talk more about Medicaid when it comes to basically having providers that are out of your network and providers in your network, because that's a new concept to me. I didn't really know that was actually a part of the system. I wanted to know if you could maybe talk a little bit more on what you've seen or you've interviewed with people who have been moving from state to state or from county to county in order to get these services provided to them, and what their experiences are as far as actually accepting those services and finding them as successful outcomes, as alternates to maybe better opportunities, but we're out of the network.
Those are, your comments are great, and the question is an important one. So one of the things I found in interviewing, I asked people a lot about access, right? Okay, you have Medicaid. How easy is it to get it? How easy is it to find a provider that you're actually allowed to go to, et cetera, et cetera? And I think that there was a lot of variation, right? So it's not that all beneficiaries said the same thing. But I will say that almost all beneficiaries talked about challenges, right? They just talked about different kinds of challenges, right? So for example, a lot of the beneficiaries that I interviewed in urban areas said, well, there are lots of doctors around who will accept Medicaid, right? But those doctors are the ones that offer the subpar services, right? And we talked to our friends who live in, I had one beneficiary who was in college. She had grown up very low income, but was sort of working her way up the ladder, right? And trying to kind of be economically mobile. And being in college had allowed her for the first time in her life to be around people who were not also living in poverty, right? It was suddenly she was in this kind of mixed class environment. And she heard her classmates talking about their healthcare and their experiences with healthcare and realized, whoa, there's a whole nother world out there. It's not that she had ever had a problem finding doctors in network, right? It's that those doctors weren't providing her with the same kind of care as was being provided to other folks who lived in other parts of the same city as her. And once she realized that, that kind of bred a certain kind of distrust of the care that she did have access to. And she said, you know, a lot of times I'll try not to go to the doctor because I know in my neighborhood it's not gonna work, right? So there's that issue. Whereas when I spoke to folks in rural areas, there was a lot more of a challenge around access, right? It was that when I get to the doctor, the services that I get are great. It's just hard to find a doctor that's accessible and in network, right? So when there are few providers, and of those few providers, if even one isn't in network, that's a significant barrier, right? So I guess my overarching point is there's no broad brush, right? But there are challenges of different kinds, essentially all across the board, which is why the policy interventions here have to be tailored. They have to be tailored. That's the way in which, like, federalism is important. A lot of people say, you're writing this book about federalism, or are you saying federalism's bad? Look, in many ways it is bad, right?
Yeah.
It breeds a kind of inequality that doesn't comport with what we think is right. Should it matter when you cross the state line, the kind of healthcare you have access to on a kind of moral or ethical level? I think most people, actually across the ideological and partisan spectrum, would say no. So that system just doesn't comport with what most people find is right. That doesn't mean that federalism cannot provide a structure that allows us, you know, to tailor our policy solutions in ways that reflect problems in particular communities in particular places. That's the upside of it, right? The downside is inequality, and so we have to deal with that downside. The upside is flexibility, so we have to leverage that upside, right? But thank you for your question.
I'm J.D. Miller, practiced for 33 years in Eastern Kentucky, and I want to offer a little bit of a corrective because I think there's often an assumption that if you're practicing in Eastern Kentucky or in a poverty area, then the quality of your work is inferior. And I don't think that's always true. In fact, I now live in the Lexington area and have had occasion to observe healthcare here. I'm not convinced that healthcare in Lexington is superior to what I was seeing in Eastern Kentucky.
Yeah, I would say that when I was talking to beneficiaries about their actual experiences, their healthcare experiences, it wasn't like the kind of the kind of rural-urban divide mattered sometimes, but it was much more likely beneficiaries in rural areas were often more likely to say, well, my healthcare is fine when I can get it, right? When I can get to it, when I get the transportation, when it's in. But it wasn't that their actual experiences with healthcare were the problem. And I should say, a lot of beneficiaries, when I asked them about like their engagement with their doctor, they were like, my doctor's great. Like there weren't as many criticisms. There were some beneficiaries that felt like they were treated differently based on being a Medicaid beneficiary. But many who said like the actual care that I'm getting, my doctor, is great, right? So I don't actually think there's a broad brush we can paint about like Medicaid beneficiaries getting substandard care in one or the other particular place. I actually think it's much more varied and complicated than that. And I think for the most part, beneficiaries appreciate their doctors and the services that they're getting from healthcare practitioners, right? It's just that it's more complicated than that. So I do try not to paint with too broad of a brush, especially when it comes to the work that the practitioners are doing. Because if there's any part of the system where beneficiaries are likely to encounter someone who they feel like actually cares about them, that's the level, right? It's not at the level of the bureaucracy. They certainly don't feel like policymakers or political elites care about them. And on a society-wide level, they feel like Medicaid is stigmatized. So if there's one part of that process where beneficiaries are likely to say, I actually encountered someone who seemed to care about me, it's at the level of the practitioner. Not across the board, not uniformly. but it's where it's most likely. It's like the furthest you could possibly walk.
You spoke about civic engagement. Could you please reiterate that statement when you were talking about it?
Oh, I feel like I said a lot of things about civic engagement, but it's worth pointing out, like, so when I say civic engagement, one of the reasons why I use that term in addition to saying like voting or political engagement is because there are important things that people do besides voting, right? Or volunteering for a campaign, or engaging in the kind of traditional formal political sphere, right? So civic engagement might be like engaging with an organization like Kentucky Voices for Health and mobilizing around the issue of Medicaid specifically. Civic engagement might be participation in an organization in your community that's doing work that you think is improving the health or well-being of people in that community. Like, civic engagement is a much broader umbrella than just voting. And a lot of political scientists think kind of about voting, and I think about it too. But it's important to me that we're thinking beyond that, because a lot of the most vulnerable folks don't understand voting to be the most immediate way to address their issues, right? And so engagement beyond voting is very important. And civic engagement is really any kind of engagement on a state, national, local level that with organizations, bureaucracies, communities that is meant to improve your welfare or the welfare of people around you, right? So that can take on a lot of different forms. And in general, negative experiences with Medicaid dampen civic and political engagement. But the variation that I find is important, because what it means is that that doesn't have to be the case. Some people say, oh, well, I guess Medicaid just makes people apathetic because we're giving them free stuff, right? No, absolutely not. What demobilizes people are the policies and the process, right? Not that we're providing them with a resource. That actually forfends against the demobilization. And so I think about civic engagement broadly, and I think about the reasons why it's dampened by Medicaid with nuance, so that somebody can't take this and say, well, I guess then we just take all the benefits away and then they won't be apathetic anymore, right? Like, absolutely not.
I'm going to make Jason walk all the way back over here.
You're burning your calories today, though, Jason. No need to go to the gym after this. I don't know if you have a Fitbit on, but if I were you, I'd be, me and my 8-year-old, I don't have mine on today, but we like compete to see who can get the most steps, you know? He always wins because he's 8. But maybe Jason would have like beat him today.
You've done such a wonderful job, I think, of capturing in your interviews what we all kind of know to be the truth. So one of the things that we know really helps is if people have somebody that they can talk to or somebody that reaches out to them. So I'm thinking about the assisters, I'm thinking about the navigators, I'm thinking about the connectors, I'm thinking about the peer mentors, so the peer support specialists that we have in substance use disorders and in mental illness. What else can we do? Who else are folks willing to listen to get them more engaged? You know, we're trying always to get them convinced that their voice really does matter, that it really does make a difference. And other than that kind of one-to-one reaching out, do you have any suggestions about how we get people to trust that there is hope, that there is somebody they can listen to, and, you know, take that next step to get active?
Absolutely. So there are two things that come to mind immediately. One is, and this is contrary to what I thought when I first started working on the book, but what I found is that more and more people seem to be turning to communities that are virtual, right, that are online. And so it's interesting, when I encountered this group of women in Iowa that were just like fierce activists, I thought, how did they come, like, where did they come from? How does this happen, right? And it was what motivated me to kind of do this case study and try to understand, how do beneficiaries get activated in this way? And many of them whom I talked to said it all started with a Facebook group. A very prominent member of the community in Iowa who had been a news reporter, had done, and then subsequent, and had been like sort of just very well known, and then subsequently had a child that had a disability. So became invested in Medicaid and the Medicaid community, started experiencing frustrations with the program, with bureaucrats. And so over about a 15-year period, she had become like known as someone in the community who's the Medicaid person. Oh, you can't figure out how to handle your Medicaid case? Go to her. Very informally. And then she decided to start a Facebook group. And it was just like her and the 20 people she knew who she thought we could communicate this way, right? Within 2 years, there were 3,000 people in that Facebook group. And they actually had to like start a new group for providers and MCOs who were coming to the page that beneficiaries were coming to try to, but what the group did was it allowed beneficiaries to use each other as resources, as mobilization, as catalysts. And someone would say, I got this letter. I mean, it's a closed group that they let me into. It's an amazing resource for beneficiaries in Iowa. And somebody say, I got this letter. Did anybody else get this letter? I got this letter. I got this letter. Does anybody know what it means? Yes, here's what it means. Does anybody know what we can do? Why don't we all go together and meet with our local they'd be setting things up right there on the page. And then the group moderators would say, okay, we'll start advertising this. We're all going to meet here. But I initially thought social media is not going to be the way for this population because there's a digital divide, right? There's an access issue, and that's absolutely true. But one of the things that they started to do was that they got donors who were like relatively wealthy people and some local civic organizations to provide some of the leaders of these groups with help, making sure that they stay connected, paying their internet bills, paying for them to get smartphones instead of the phones that you can't see anything on. And so there was a provision of the infrastructure that helped to diminish some of those gaps so they could then communicate in this new way. And so I think that social media is a resource, but not a resource that we should expect will just naturally catalyze people. Instead, a resource that we can actually, that is malleable and that we can use to kind of allow people to connect to each other. Beneficiaries are motivated by each other too, right? And by kind of being able to connect with people who they can make common cause with. So that's one thing. And the second thing is local community organizations that don't have anything to do with health can be really important because they have developed, some of these organizations have developed trust in communities, in very localized communities. And they just work on, so I was in Tampa Bay last year and I was there for a few days and I gave a talk with the Tampa Bay Healthcare Collaborative. And so I gave that talk and they said, but we don't just want you to give a talk to the collaborative with all the health policy advocates and people in the room because we have some local organizations that really do like super nitty-gritty level community work. And we want people in they have clamored to us to make sure that people in the community understand this research that you've done. And they arranged an entirely different event at a local community college, and all of the local community organizations that they work with advertised, and hundreds of people came just to have a conversation about, it was a predominantly Black community, about race, poverty, healthcare. And many of the people in the room were learning. And they have been mobilized and come there because of a connection to the local NAACP, to the local Urban League. The local Urban League had done a lot, and the local Urban League had partnered with a kind of workforce development organization that helped a lot of TANF recipients to find work, and had brought, so there were all these people there who are the kind of people who are normally not having these conversations, the very kind of people, and first of all, it was just amazing because they were all like, wow, this is exactly why we don't vote, right? This is exactly why we want nothing to do with the system. But then by that being put on the radar, they were like, wait a minute, this isn't cool. If we all feel this way, and it just generated this kind of conversation, and a lot of the local orgs, the folks at the NAACP, the Urban League, they said to me, okay, we're gonna use this as a jumping off point. We need to start talking to people about healthcare. We've been helping people sign up for Medicaid when they need help, but we haven't been making the connection between that and engagement. And so it really struck me how like connecting to local organizations that may seem like they have very little to do with healthcare, but are embedded in communities in the way that give them leverage and kind of using that to build civic infrastructure, right? Because really it's a question of how do we build civic infrastructure? And, you know, we can do it in a meta way, in a kind of macro way through social media. Then we can do it on an on-the-ground way, in a micro way, through local community groups.
Thank you.
I wanted to make a comment about how these are things that we can do. We've been doing managed care for 25 years, which is really sort of amazing because we started in 2000 with 2 little organizations. And the first thing that I discovered was that the Medicaid agency was a processor. We had almost no healthcare people in the agency. So I raided public health to see if I could get some of those people. But my question is, how can we get Medicaid to start thinking not about being a processor, but about doing more of these WIC things? And maybe the MCOs have a better chance because they can be more flexible. But I'm not sure. What can we do to encourage the MCOs or whoever the organizations are to think more like you talked about WIC strategy, you know, think more like that?
Yeah, that's a great question. It's hard for me to think, so the most immediate answer that comes to mind for me is literally by talking to as many people who are in positions of power, either who are leading MCOs, and from the Medicaid side, Medicaid directors and sort of top-level bureaucrats as possible, right? That's a kind of, there are limits and constraints that those folks face, and there are challenges sort of engaging with them. But the same thing that I referenced earlier in DC, so the director of DC and Medicaid was there. It was a small group of maybe 20 people, but also the director of a kind of major MCO that primarily serves the DC area was there. And it was a really invaluable opportunity, but one of the things that struck me in that meeting was how it felt like we were completely talking past each other. Like these things that I'm thinking about and talking about, like, are just not what the Medicaid director is thinking about. You know what I mean? Because, my gosh, she has so many other things she has to think about. And so there's a disconnect between the folks at the kind of heads of these agencies, and to some extent, like, if those folks get on board, there's a lot they can do to transmit that message down. So there's a kind of that idea of the top-down approach, and then, which I'm always kind of cynical of top-down approaches. I'm always like, I don't know if that'll work, but it's worth thinking about them. And thinking about what are the ways to actually connect with these folks and convey some of these ideas to them. And there are different kind of leadership development programs and things like that that RWJF and other folks are doing to try to connect more with Medicaid directors and MCOs and some of the kind of leaders in these agencies and arenas to help them to start to think more consistently and carefully about consumer engagement, right? Which is a language that not all of them really think in terms of, right? So that's one thing, and I think another thing is like, so that may feel hard, right? Like, oh my gosh, how does that actually happen? And part of this is where I think networks really matter. I think identifying and sort of successfully bringing on board even a handful of, say, Medicaid directors or MCOs that are willing to like take these things seriously, and then having concrete proposals that you can make to them that are kind of place specific and specific to kind of what they do, what populations they serve, etc. And then tracking that and being able to say, okay, we tried X thing in X place, in Y place, we tracked what happens, and we now have evidence. This is what happens when MCOs take seriously consumer engagement, right? And I think I can't think of a way to kind of make this happen broadly like now, you know? But I can think of the building blocks for generating evidence that when we get different stakeholders on board with mobilizing and engaging other stakeholders, and then we see what happens, then we can be able to make more and more of a case that more and more folks should be doing this because we have evidence about the value of it. I think some of that is already happening and is already being developed, frankly. And it's just a matter of kind of keeping that ball rolling, expanding it in different ways to different places.
I was thinking less of consumer engagement than I was about focusing on health.
Yeah.
So that is their job, and if they acted like the only thing that they had to do is understand what it would take to get people to be more healthy,
Oh, yeah.
that's what they heard, and that's what they did something about.
Well, some of that is like training, right? And what these folks understand their job to be. So my co-author at Duke, Carolyn Barnes, she interviewed a lot of bureaucrats, and often it was the same person administered WIC as Medicaid, right? Like in a lot of agencies, these things are pooled, right? But she asked them, like, do you take a different approach when you're administering WIC versus when you're signing people up for Medicaid? Oh yeah, of course, they're totally different programs. And she literally got copies of like the kind of manuals that they're given to tell them about how to engage the applicants for these different programs. And there are pretty striking differences. Like some of this stuff is like, the folks working in these offices, the kind of street level bureaucrats, are doing what they're told to do and what they're trained to do, right, on the one hand, and are doing what reflects how they think about these different populations, which goes back to our kind of public perceptions and stigma. Women, children, like I deal with this group differently, and I may still be dealing with some of the same people over here, but I think about Medicaid and what it is and who it serves differently. And then the manual tells me to do different things, the policies are different, and so there are so many layers there that send the signal to the street level bureaucrats. We handle these different programs very differently. The question is, how do you change those signals? And some of it is like what you're telling the bureaucrats to do, and holding those folks accountable, right? But that's not really a solution because it's not easy to make happen.
It's changing culture and how you think about what you do.
Yeah.
It's because people don't think about what are you actually trying to do is
To improve the health of people, but you can't improve someone's health if you don't address the social determinants that go along with health. So we tend to look at health in a very narrow box. So I have a diagnosis, I have a treatment plan, you need to go do it, and if you don't do what I tell you to do, now it's all your fault. But we don't think about, is it realistic to the person's situation? And we try to standardize things, which makes it easier for maybe someone who's administering a program, but it doesn't necessarily make it realistic or helpful to the person who's receiving the service. And so it's the idea of who's the service about? Is it about the person who's administering it, or is it about the person who's receiving it? And this should be about the person who's receiving it.
Yeah.
So the mindset should be, what are we delivering and who is our target audience and what do they say about it from the very top all the way down? And unless everybody's thinking that way, it gets hung up in processes, it gets hung up in procedures, it gets hung up in I'm having a bad day and I don't want to deal with you, and it gets hung up in my perception about who these people are that I'm serving, that I don't trust to be able to make a decision that's good for them on their own. I have to do it for them.
Yeah, and so this is exactly right. And I think saying it's about culture change sometimes is like intimidating to me because it's like, how on earth do we change culture? It feels like a really high bar. But this is where some of the kind of process-oriented things that I mentioned earlier come into play. Because, for example, organizational cultures change when there are different people whose voices are amplified in the organization. And so I was talking to some folks in Buffalo who work with state legislators and who propose to them, why don't we do this? We will find a kind of advisory board of Medicaid beneficiaries who are just regular beneficiaries from different, kind of categories of beneficiaries. And all we want you to do is when you're considering some administrative bureaucratic change or some kind of policy change, that you commit to like engaging with our advisory board and getting their perspectives on it, right? And they had told me about how productive that had been for them. Because like the Buffalo City Council would be like, we're gonna do X, and then they'd say, okay, we'll meet with our advisory board, and they'd brief the beneficiaries on their advisory board beforehand. They wouldn't tell them what to say or what to think, but they'd kind of brief them, because some of this stuff can get pretty complicated and in the weeds, and they'd kind of make sure they felt prepared, and they'd help them in different ways. So you need to get the day off from work, so you can meet with them. We'll help you talk to your employer, we'll help you get there. So they provided the infrastructure to make it possible, and then they put the Medicaid consumers in the room with the people who were making these proposals. And when those folks left the room, they were like, wow, well, there are some aspects of this we hadn't thought about, right? And that's how you start to work toward culture change, by bringing different voices into the room, amplifying different perspectives, so that we're forced to think differently, right? But that kind of thing I haven't encountered in many places, right? The kind of consistent inclusion of voices that will enable the broader culture change. All right, I think we're done. Thank you all. You got, one more? You all have gotten a lot of me today, so I'd be done if I were you.
Really, I've sat here and had a lot of turmoil, and had to look at myself really close. Now, there's several people in this room that know me and know that I love people, and I'm very empathetic, and I care. However, there was a part of me, as I heard our farmer talking, I'm of age, brought up with farmers, love farmers, but there was a part of me that said it's something to do with the difference of us older folks and the younger folks, because we were used to working 12, 14, 16 hours a day. And when my family couldn't get health insurance, they became a school bus driver and had to cut up their days to work in the field, but they provided their health insurance. So my mind is going around and around, trying to think that through and not being judgmental and prejudiced. And I think that's two words that probably is affecting our culture so much. And I think that we all, and especially me at this point, need to look inward and think, maybe I'm a little more prejudiced than I realized, and that will change the culture.
Wow, well, I will. If that level of honesty and introspection was something that we could all bring, right, in this room and outside of it, to the policy and other processes that we're talking about today, it would change our whole country, right? It would change a lot. It's hard, it's challenging. I think this is a kind of parallel. In my department a few years ago, some of the graduate students who were women came to me and said, well, you just started working here, and you're closer to our age than some of the older faculty, and we want to talk about some of the challenges for women and mothers in academia, and we want a venue to talk about this. So I pulled together my colleagues and said, oh, maybe we can have like a biannual thing where the women faculty, women students get together and talk about some of the challenges that we all navigate. And one of the things that I found was that some of my older colleagues would sort of sit in these meetings and kind of roll their eyes, like, oh my gosh, yeah, I went through this times 100. And now you guys are all complaining, we need help, and give us, I went through it. And it's a form of kind of minimizing and in some ways trivializing someone's burden, because you had that burden too. Or maybe you had more of a burden, right? Or you perceive yourself to be. And we do it in all sorts of ways, right? I was teaching in my class, my public policy class last week about, or my poverty class. I teach a class on poverty in the US about race and poverty. And I had a student who was Irish who said, well, my great-grandparents came here with nothing, and Irish Americans were discriminated against, and they managed. So what's wrong with black people, right? And he didn't say it like that, but he basically
Yeah, he did.
he basically said it like that, but because he said it to me, it was slightly nicer. And it's this, we all fall into that, right? We can all fall. It can be about age, it can be about gender, it can be about race, it can be about a number of things. it's difficult for us to connect with, truly empathize with, even if you're an empathetic person. You empathize with lots, you really care about the world, right? And sometimes across those lines of experience is just difficult. And you know, I always tell my students, like, just because someone at some point somewhere can overcome this barrier, it doesn't mean that the barrier is okay, right? It doesn't mean that people should always keep having to overcome it. We can still think about what it means to remove that barrier, what kind of quality of life people could have, what sorts of things might have been possible for your family members if they didn't have to do that, right? What sorts of opportunities, ability to engage and raise your family. Oh, the world could be a different place, right? But we have to change our thinking to get there. And it means that we have to be self-critical. I'm self-critical all the time, right? I mean, I think when you teach a lot of students, I have students who come to me who are super staunch conservatives, and students who come to me who have completely different life views, who say things to me that I find like deplorable and objectionable. I have students who say, well, why don't we, you know, I had a student last year who said maybe the reason why, you know, African Americans haven't been able to get ahead is because they're just inherently cognitively not able to, right? And so here I am in front of a class of 150 students debating whether black people are inherently inferior, right? So my inclination is not to think about where is this coming from? How can I engage this person? Do I agree with him? No, on no level. But what does it mean to have a kind of civil engagement and to try to understand this student's perspective without meaning that I agree with, and there's a lot in our politics that requires us to kind of push ourselves outside of our comfort zones, outside of our instant reactions and instincts, to think about how can we cultivate something better, right? And that's the culture change that we're all reaching for, but it's really, really hard. But thank you. Thank you for sharing that. Thank you all.
Well, I think we're ready for a break, but please, this has been an excellent conversation. So I really appreciate everybody having such thoughtful questions and comments. I mean,